Welcome. Today, we're diving into a really fascinating area of medicine, mood stabilizers. And what's so wild is that a lot of these drugs started their lives as something completely different. They were made to stop seizures. So how on earth did they make the jump from treating epilepsy to treating mood disorders? Well, let's get into it. I mean, it's a great question, right? It sounds kind of weird. You've got a drug that's meant to calm the electrical storms in the brain that cause a seizure. How does that same medicine help balance the intense emotional highs and lows of a mood disorder? That's the exact puzzle we're going to piece together today. So here's our game plan. First, we'll cover some really important ground rules for this whole class of drugs. Then we'll meet the original, the gold standard, lithium. After that, we'll get into the real heavy hitters, valproic acid and carbamazepine. Then we'll look at a medication that's more of a maintenance specialist, lamotrigine. We'll put a huge risk under the spotlight to make sure we understand it, and then we'll wrap it all up with the key things you need to remember. Okay, first things first. Before we even whisper the name of a single medication, we have to talk about the rules of the road for this entire family of drugs. And these aren't just, friendly suggestions. They are absolutely critical for using these medicines safely and effectively. You've got to respect these drugs for three big reasons. One, they demand constant monitoring. We're talking regular blood tests to check drug levels, liver function, kidney function, the works. Two, a lot of them carry a really high risk for causing birth defects. And three, they can mess with other medications in a big way through something called the cytochrome P450 system in your liver. You can think of that system like the main traffic hub for processing drugs. These mood stabilizers can either cause a massive traffic jam or put a turbo engine on the system, which affects every other drug on that highway. All right, our first stop is the OG, the original mood stabilizer, lithium. Now, technically, it's not an anticonvulsant, but you just can't have this conversation without starting here. It's the benchmark. It's the standard that all the others are compared against. And this quote really gets right to the heart of it. Yeah, it's the gold standard for mania. But what makes lithium truly, truly special is its proven ability to lower the risk of suicide. That one property alone makes it an absolutely vital, life-saving tool in psychiatry. Now, here's one of lithium's biggest challenges, that therapeutic range. The window between a dose that works and a dose that's toxic is incredibly small. We're talking a razor-thin margin between 0.6 and 1.2. This is precisely why that constant blood monitoring isn't optional. It is 100% non-negotiable. It's like walking a tightrope. And, of course, there are risks to watch for. Common stuff includes things like a tremor or weight gain, but a huge one to keep an eye on is hypothyroidism. It can slow your thyroid right down. Dehydration is also public enemy number one, because it can cause lithium levels to spike into that toxic range really fast. And for pregnancy, there's a specific risk of a rare heart defect called Epstein anomaly. Okay, now we're getting into the anticonvulsants that were repurposed as mood stabilizers. And we're starting with the two big guns, the heavy hitters, valproic acid and carbamazepine. These are really powerful, really effective, but man, they come with some serious warnings. First up is valproic acid, which you might know as Depakote. It's definitely good for acute mania, but its real claim to fame, its superpower, is how well it works for patients with rapid cycling bipolar disorder. That's when a person has 4 or more separate mood episodes within a single year. The risks here are no joke. We're talking multiple black box warnings, which is the FDA's most serious alert. These include the potential for serious liver damage, pancreatitis, and a very high risk of causing severe neural tube defects in pregnancy. That's exactly why it's a huge no-go for most women of childbearing age. Next up, our other heavy hitter, carbamazepine or Tegretol. And if this drug had a personality trait, it would be this. It's a potent inducer of that cytochrome P450 system. Remember our traffic controller? Well, carbamazepine basically hits the fast-forward button, making the body break down other drugs way faster, and that can make things like birth control pills a whole lot less effective. Its black box warnings are also really serious. There's agranulocytosis, which is a dangerous drop in white blood cells, and a severe skin reaction called Stevens-Johnson syndrome, or SJS. And this special note here is absolutely critical. People of Asian descent need to be screened for a specific gene before they ever take this drug, because it dramatically increases their risk for SJS. So seeing them side by side really helps keep them straight. Think of it this way. Valproic acid is the specialist for rapid cycling, and its biggest warnings are about the liver. Carbamazepine is that powerful P450 inducer, with its biggest risks tied to your blood cells and skin. And while both are bad news in pregnancy, they can actually cause different kinds of birth defects. Okay, our next drug, lamotrigine, plays a totally different role. If those last two were the heavy hitters for putting out fires, lamotrigine is the maintenance specialist. Its main job isn't stopping an acute episode, it's prevention. It's all about keeping future episodes, especially depressive ones, from ever happening in the first place. With lamotrigine, there is one rule to rule them all. Start low and go slow. You start with a tiny dose, and you increase it incredibly slowly over weeks. This whole careful process is designed for one reason and one reason only: to avoid that dangerous side effect we just mentioned, Stevens-Johnson syndrome. Any rash on this medication is a stop sign, period. So, we've brought it up a few times now, and it's so important that we need to put Stevens-Johnson syndrome, or SJS, directly under the spotlight. It's rare, for sure, but it is so serious that anyone who might take these medications needs to know exactly what it is and what the warning signs look like. So what is this thing? Well, SJS is a severe full-body allergic reaction. It's a true medical emergency where the skin and the mucous membranes, like the inside of your mouth and your eyes, have a violent reaction, usually to a new medication. And this timeline is so crucial to understand because SJS is sneaky. It doesn't just show up overnight. It usually starts about 1 to 3 weeks after you start a new drug, and the first signs can look just like the flu: a fever, a sore throat. Then comes the painful spreading rash. If it keeps going, the skin can actually start to blister and peel off. If there's even a suspicion of SJS, the response has to be fast. There's zero time to wait and see. Step 1, stop the medication immediately. Step 2, get to a hospital, maybe even a specialized burn unit. And from there, it's all about supportive care, managing pain, preventing infection, and keeping the body hydrated. Whew, okay. We have covered a ton of ground. So let's zoom out in this final section and really lock in the key takeaways from our explainer. Here's your quick and dirty field guide. If you only remember a few things, make it these. Lithium is the one-of-a-kind anti-suicidal gold standard. Valproic acid and carbamazepine are the big guns, the powerful heavy hitters, but they come with heavy risks. Lamotrigine's whole philosophy is start low, go slow. And finally, SJS is a rare but very real medical emergency, and knowing those early flu-like signs is key. You know, at the end of the day, all of these medications are incredibly powerful tools. They can be absolutely life-changing, even life-saving. But using them well always comes down to this delicate balancing act, weighing the massive potential benefits against some very significant risks. And that really leaves us with one last thing to think about. When you have this complex web of risks and benefits, and you factor in each person's unique situation, how do clinicians and patients even begin to make that choice together? How do they navigate all of this to find the right path? That conversation, that partnership, that's maybe the most important part of this whole story. Thanks so much for joining us.